Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and as you may know, March is Colorectal Cancer Awareness Month. Today, we're joined by Dr. Jeff Harris, colorectal surgeon, Dr. Kevin Chen, medical oncologist, and Emily Kaczynski, genetic counselor. We're going to discuss colorectal cancer, its risk factors, how it can be detected early, treatments, and more. So I invite you to stick around, share this broadcast with your friends and family, give us a like, let us know you're watching, and ask your questions for our experts in the comments below. So before we get started, I would like to introduce you to our panel and get to know a little bit about them. So first of all, thank you all for joining us today. Let's start with Dr. Chen. Can you introduce yourself to our viewers?
Sure. So my name is Dr. Kevin Chen. I'm a medical oncologist here at Franklin Square. I've worked here for about 7 years now. This has been my first job straight out of training, so my very first job, and have become very, very busy and seeing all types of cancers. But lately I've been focusing a lot more on colorectal cancers and GI cancers. So this is a very, this topic we're talking about today is very dear to my heart, and something that I'm very interested in engaging the community and my patients about.
That's great. Thank you. Emily, would you like to go next?
Yeah, hi, good afternoon. I'm Emily Kaczynski. I'm a cancer genetic counselor with MedStar Health. I've been with MedStar for over 10 years, and I see families who are at risk for all types of cancer. But I also, like Dr. Chen, hold colon cancer close to my heart because up to 10% can be inherited. And so we really strive to try to identify those families who are at high risk so we can offer them early detection and additional screening. So happy to be here today.
Thank you. And Dr. Ferris.
I'm Jeff Ferris. I'm a general and colorectal surgeon. So I've been here at Franklin Square more than 20 years. Some of the work I do is with an incision and some is with a robot. And I know about colonoscopy to comment on some of that. So this is my home, I guess.
Great. Well, thank you so much. Thank you all for being here. So we have some questions for you. And again, to our viewers, if you have questions as we discuss colorectal cancer, please ask them in the comments and we'll ask those to our experts as well. So Dr. Ferris, let's start with you. What exactly is colorectal cancer?
Like Emily said, it can be inherited, or you could be the first in your family with it. So typically there's a polyp cancer sequence where for some reason, genetically or not, the lining of the colon, the inner lining, the mucosa, things can start to change or proliferate or grow. So most colon cancers start as a polyp and then get larger over time, grow deeper, and then if they're biopsied and penetrate the inner layer of the bowel wall muscle, then by definition, it's become a cancer.
Okay, thank you very much. Dr. Chen, can you talk about the biggest risk factors for colorectal cancer?
Yes, so there are many. Some of them you cannot control, meaning something you're born with. So inherited genetic components, but also age. As we get older, cancer risk just goes up for almost all cancers, and definitely for colorectal cancers. There's also some other medical issues that some people are born with, such as inflammatory bowel diseases like Crohn's disease or ulcerative colitis. Those patients are at much higher risk of having colorectal cancers, especially at a younger age. So those are some of the risk factors for those that you can't control. But there are some that we can control. For example, smoking. Smoking is one of the worst things people can do. Your health is at horrible risk anytime you smoke. And colon cancer definitely goes up with smoking, as does alcohol. Sometimes also diet. So, processed meats has been shown to increase the risk of colorectal cancers. And then also just leading a sedentary lifestyle. So those that are not active, not exercising, that increases the risk. And going along with that is obesity. So these are all things that we should be, educating our patients about to try to lessen their risk as much as possible.
Okay, that's very good to know. Thank you so much. Emily, question about kind of going back to those risk factors. Are some people more at risk than others for colorectal cancer?
Yeah, sure. So like Dr. Chen said, there are various risk factors. Some are just as simple as, we're all at risk getting older, and then others are certain lifestyle and environmental factors. But for those that have that genetic risk factor, their risk for cancer can be 5 or 10 times higher than average for colon cancer. So, most people are looking at about a 5% risk for colon cancer in their lifetime. But if you have that genetic risk factor, your risk can go up over 50% risk that you can get colon cancer. And often that's at earlier ages. So that can be helpful to know if you have that genetic risk factor.
Yeah, thank you so much. Well, Dr. Ferris, can colorectal cancer be prevented?
Sure. It would mean sometimes knowing your own family history. So if a parent had colorectal cancer at a certain age of diagnosis, you might begin screening earlier on instead of age 50, which has traditionally been the start for anybody without any symptoms or family history. They've moved that up. The societies have come together to start screening at age 45. So that's one thing. And if you have a colonoscopy on time, and if polyps are found, like I alluded to first question, I mean, these polyps can be removed before they grow larger or deeper or become malignant. So with the colonoscopy, that's also diagnostic, but therapeutic, to run a snare through a long flexible scope and pinch off a polyp. Polyps are often flat or mushroom shaped, and to somehow raise it up and snare it and remove it, you're ahead of the game.
Okay, thank you so much. I just want to pause for just a moment because we have some new viewers that just joined us. I want to welcome all of our viewers who just joined. We are talking today with Dr. Jeff Ferris, colorectal surgeon, Dr. Kevin Chen, medical oncologist, and Emily Kaczynski, genetic counselor. We're talking about colorectal cancer, risk factors, detection, and treatment. So we've talked about what colorectal cancer is, those risk factors, your genetic risk, warning signs, and prevention. So let's talk a little bit more with you, Dr. Ferris, about the screenings and the guidelines that you started talking about a little bit earlier. Can you first start talking about the different types? Are there different types of screening tests available?
Still
we know colonoscopy, of course.
Colonoscopy is the gold standard, and
Yep.
most physicians would agree with that. And
Okay.
what's come into vogue potentially during COVID times is the Cologuard test, which is a test of DNA shed within the colon. So it's better than nothing. I think even on TV, they describe it picks up 92% of all colon cancers. So that's good, but still colonoscopy is the gold standard. There's still old school ways to be screened or checked. A flexible sigmoidoscopy is a shorter scope. You're not sedated, and it's a different bowel prep. But still, there's some studies out there that quote doing a flexible sigmoidoscopy every 3 to 5 years, a digital rectal exam, and stool for occult blood, a little stool card for blood every year. So there are different ways out there. And one more time, the colonoscopy is the gold standard.
Yep, that's good to know and to reiterate. Thank you so much. What are the guidelines for screenings?
So like I mentioned earlier, now the age to start is 45 because we're seeing younger people with colon cancers all the time. And, I think what's brought it to light is there was an actor in the movie, The Black Panther, who apparently had been acting while he had colon cancer and somehow, later succumbed to the disease. So that's sort of brought it to the forefront. So the screening begins earlier for others with some of these genetic syndromes. Maybe Emily would want to comment further, but there's a Lynch syndrome, a familial polyposis syndrome, and some of these, the guidelines aren't simply to start at 45 and then every 10 years if they've found nothing, but even every 1 to 2 years with the Lynch syndrome kind of family history. So if polyps are found, then there's certain rules of how often you have to go back. So if any exam you're found to have polyps, if it's 3 or more polyps, you go back in 3 years. If one polyp is as large as 1 centimeter, that's a little less than half an inch, you go back in 3 years. And if it's a lesser number, every 5 years, and that would be forever. And with the family history, if it's a parent that's a first-degree relative or a sibling, a brother or sister that's a first-degree relative, then you begin usually 10 years before that diagnosis was made in the family member and every 5 years thereafter. And having said all that, if somebody's got rectal bleeding, diarrhea, constipation, some change in their bowel habits, they can go anytime and tell their physician this, and they deserve a colonoscopy.
Yep, that makes sense. Thank you so much. What would you say to someone who is hesitant to get a colonoscopy? I know that there's prep work involved. There's some uncomfortableness maybe to it. What would you say to someone who is hesitant? Obviously, it's important to get that colonoscopy, especially for all the reasons that you mentioned and the guidelines that are in place. So yeah, what would you tell our viewers who are thinking to themselves right now, okay, I'm 45, I need to get a colonoscopy, but I don't really want to. I'm nervous about it.
Well, it's amazing how many people have a friend or an acquaintance who's had colon cancer and wish they didn't. So, I mean, it's so much easier to spend a day out of your life every 5 or 10 years and do this and catch something early. I mean, the difference would be a major abdominal surgery. Nobody want that either. So a colonoscopy is so simple in comparison.
Yep, that's a good way to look at it. Thank you so much. So through all those different tests that you mentioned, Dr. Ferris, and obviously the colonoscopy being the gold standard, can you talk about when or how is colorectal cancer diagnosed?
Sometimes there's some symptoms, change in bowel habits, rectal bleeding, not so much the change in caliber of the stool, but abdominal pain, anorectal pain. So sometimes there's symptoms and sometimes not. I mean, the colon and rectum, if you sort of measured it and stretched it out, might be 4 to 6 feet long. So the upper colon is on the right. As things go, the stool passes from the right side across the middle, down the left side and out. And people with upper or right-sided colon cancers may have few, if any, symptoms. They're not going to see blood loss. They're not going to see blood. They may have no symptoms. The first thing they may notice is being weak or short of breath, a sign of anemia, because this mass, this colon cancer, has shed blood a little bit at a time over months or longer. So, therefore, it's not simply that I don't have any rectal bleeding, it's okay. And it's not as simple as, hey, I know I have hemorrhoids and rectal bleeding, so everything's okay. I mean, you deserve to be checked. I mean, I've had it posed to me the opposite way. Dr. Ferris, would you ask your patient to lie about their symptoms in order for them to get a colonoscopy? And of course, I'm not going to go on the news and tell people that, but it's just, that important that people should get it done.
Yep. Thank you for that. So if you are diagnosed with colorectal cancer, can you talk about how it would be treated and when is surgery the best treatment option?
So we've already said a few times, the value of colonoscopy and discovering polyps and removing them early.
Yeah.
But even if a polyp can't be removed, or if it's become malignant, obviously the earlier you catch it, the better the chance you have of beating this thing. So there's preoperative staging, you can quote numbers to people, but essentially the earlier it's picked up, the better. So in terms of treatment, this may be too deep, but actually rectal cancers are a thing of their own. I mean, I think the colorectal surgeon usually is best to treat rectal cancers. Your general surgeon can too, but maybe more comfortable with colon cancer. So colon cancer, usually people get surgery first, and only if it's spread further would they get chemotherapy first and see what happens with the tumor itself. But rectal cancers can be staged preoperatively, and sometimes if they're at a certain stage, they will get radiation and chemotherapy up front. Last night we had, if this is interesting, a colorectal journal club, believe it or not. We sit and talk about the German study and these studies from other countries as well, and something that never would have been thought of years ago. Some people with rectal cancers respond well to radiation and chemotherapy, and almost then, instead of a big surgery removing the entire rectum, there are thoughts of now what's called watch and wait. If the cancer responded that well to the radiation and chemotherapy, maybe not to even have to proceed with the radical operation.
Okay, thank you very much. Dr. Chen, can you talk a little bit more about treatments? Dr. Ferris mentioned some other options other than surgery. What else would you like to add to that? Are there new treatments being explored?
Sure. So colorectal cancers, the treatment is not the same for everybody. It depends on a lot of different factors. Like Dr. Ferris alluded to, some of it depends on the location of the tumor. So is it in the colon or is it at the end of the colon in the rectum? That's, we need to decide where the tumor is located. And also factors are the stage, early stage versus late stage. So early stage cancers are when it's just on the surface of the colon or rectum. Medium stage is now it's kind of penetrating more through the walls or spreading to some of the lymph nodes nearby. And then late stage is when it's spreading to the rest of your body. So it really, we have to figure out where do you fall on that spectrum. And then other factors are the patient, how old are they? What other medical problems do they have? That all factors into coming up with a treatment plan. And, oftentimes you need a multidisciplinary approach where, a surgeon like Dr. Ferris and myself will discuss a patient, and radiation oncologists will be involved as well as the gastroenterologist. We all have to discuss cases together to figure out the best treatment plan. And then when we do come up with the treatment plan, we then of course discuss with the patient and make sure they're on board. But there are cases where we do surgery first. Dr. Ferris will take a patient to this operating room and remove the cancer. Then we find out how much cancer was there, what other what other features of the cancer will tell us how aggressive it is. And then we'll determine if they need more treatment after surgery, like chemotherapy to clean up and kill off any of the tiny little cancer that might still be floating around, because we don't want the cancer to come back in the future. So sometimes you need more than just surgery. It sometimes can be a little bit more complicated, and that's why you really need to get in with a team of doctors to discuss it. And then you asked about kind of new treatment approaches, and we're always trying to do better. So we have we've come a long way from where things used to be. But there's been so many advances in surgical techniques and ways we deliver radiation. And in my world, the medical oncology world, there are many new treatments that we didn't have before. So chemotherapy has been around forever, and it's effective and still a major part of our treatments. But there are newer treatments out there as well. For example, immunotherapy. That's probably been one of the biggest developments in the whole cancer world, all types of cancer, where we're now utilizing a person's own immune system to fight the cancer. And oftentimes this is much more effective than chemotherapy, or can enhance the effects of chemotherapy in killing cancer. And it has sometimes the added benefit also of less toxicity, less side effects. So it really is a win-win for many, many patients. And a lot of us hope that this is going to be the future of cancer treatment, where we can move away from some of the older treatments like chemotherapy and focus more on immune-based treatments. And then I think one other newer, another big new development in cancer treatment is targeted therapy. So this is kind of goes along with what we call personalized cancer medicine, where we take a patient's tumor, we run it against panels of mutations and testing to figure out what is driving that person's cancer to grow on the smallest molecular level. And when we know that, we can then treat that individual patient the very best way. We can figure out what drugs will be the most effective, and sometimes that involves pills. Nowadays there's actually cancer pills that can counteract some of these mutations we're detecting. So, I think that there's, we've come a long way. Patients are doing better now. Prognosis is better. Patients are surviving longer, but, we still have a long way to go. And, I think we're moving in the right direction.
That sounds great. That's very exciting. And so it sounds like the treatment options are really personalized to you and what you discuss with your team based on all the factors that you mentioned. Dr. Chen, can you talk about side effects of treatment? And I imagine it would depend on the treatment that you end up getting, but can you talk just maybe generally about some of the typical treatments that you see and some of the side effects that could come with that?
Of course. I mean, when people think of cancer and they come see me, the first thing they're thinking or worried about is chemotherapy, because there's a lot of people know a lot about chemotherapy or something about chemotherapy, if they're a family member or, even how it's portrayed in the media on TV or movies, they have some idea. But, we always have to educate our patients that, chemotherapy is not the same for everybody. There's different drugs that have different side effects and they affect people very differently. For example, in colon cancer, a lot of the chemotherapy drugs we give don't cause hair loss. That's one of some patients' first biggest worries, which I understand. It's a big deal for a lot of people, but we educate them that a lot of our drugs actually don't cause hair loss. But some of the other side effects are true. So they can cause some nausea, can cause some vomiting sometimes. It can cause diarrhea. Some treatments can cause weakening of the immune system. And that's a very big deal, especially nowadays with everything going on in the world with the COVID pandemic. A lot of people are worried about their immune systems, and it is true when you're on chemotherapy, your immune system will be weakened, and so that is a big concern. But in general, we now know how to manage these side effects of chemotherapy much better than we did in the past. Almost all of it is now outpatient. Meaning you're not in the hospital for these treatments. You come from home, you come to our office, you get your treatments, and then you go home. And, we give you the medicines you need to counteract these side effects. The nausea, we give you nausea medications. Infections, we can give you shots to boost up your immune system. So there's ways for us to get you through it, to get you through these treatments. And then some of the other treatments that, nowadays we're talking about is the immunotherapy side effects. That's a big thing now. And I said that they are, in general, better tolerated than chemotherapy, which is true, but they have their own side effects as well. Sometimes they inflame things in the body. People get rashes, or it inflames your colon, you get diarrhea. These side effects are pretty rare, but, there are things that we also, we as their doctor has to be very aware of and educate our patients on things to look out for and to always be in touch with us if anything comes up so we can direct them to get through that.
Thank you very much. That was helpful. Before we start talking about genetic testing and that factor that is involved in colorectal cancer, I do have a question from our audience. I'm going to send this to Dr. Ferris. So going back to colonoscopies, we know that's the gold standard. It's important to get them so you can check to see if you do have colon cancer. This question was specifically about the prep work involved. What is the current prep for a colonoscopy? What would someone need to do? What's the process for that you have to go through before you go to get a colonoscopy?
Well, it's changed over the years, and I think it's become simpler. So way back when, it was a 10-ounce bottle of magnesium citrate. But I mean, there's enough of a salt load that you have to be careful with somebody's kidneys with that kind of thing. There was a pill prep, an Osmoprep pill kit, which was 32 pills. And by the time you ate all the pills and drank all the fluid that went with it, you know, you're equal to that gallon of Go Lightly that people joke about. But I mean, in our own clinic, so a plug for the Center for Digestive Disease here, the colorectal surgery team is coupled with the gastroenterology team. Almost everybody uses a Miralax prep. And it may vary how much volume total the day before, but it's really pretty simple. And I don't really hear people complain as much about the prep as they used to with those that I mentioned first.
Okay, great. Good to know. No, especially knowing that things have changed over the years. So thank you for that question. If you have any other questions, please ask them in the comments. We're going to talk with Emily about the genetic side of colorectal cancer. So Emily, my first question for you is, how are genetic risks identified?
Yeah, sure. So we look for certain red flags in the family. So we've been talking about colon cancer diagnosed at young ages. So that's probably one of the biggest red flags, because most people who develop cancer will be over the age of 50. So if a person or a family member has colon cancer in their 30s or 40s, that's a concern that it could be genetic. And then also if they have multiple generations of the family with colon cancer, because that can be a sign that there's something in the DNA that's getting passed down from generation to generation that could be putting that family at risk. So if a person or their family has those red flags, I recommend they ask for a referral to a genetic counselor if they haven't already been referred. And a genetic counselor can take a deeper look at their family and give them an assessment and offer them genetic testing, which genetic testing itself is simple to do. It's either a blood test or a saliva, looking for those inherited DNA mutations. But there's a lot that goes with genetic testing. So we like someone to be informed going into that test to think about, do they want to know that information? Do they want to know that they're at high risk for cancer? And also the options that come along with that. Are they open to, you know, starting those colonoscopies sooner, doing them more frequently? And then often there's other cancer risks that come along with the inherited colon cancer syndrome. So sometimes that person can also learn that they're at high risk for GYN cancers like uterine and ovarian cancer. So we talk about the options there that they have for screening and prevention. So genetic testing, it's easy to do, but I would highly recommend someone sitting down with a genetic counselor so they can really walk through that information that is to be had and make sure it's information that the family wants, and also that genetic counselor can support them once they do get that genetic test result with kind of what the next steps are. You know, when should I start my screening? What screening should I have? Who else in my family could have that genetic risk factor and should be offered testing?
Thank you very much. So just to, and I think you answered this already in your explanation earlier, but just to reinforce, so if I'm someone who has colon cancer that runs in my family, what should I do? I guess can you remind our viewers, what is that first step?
Yeah, so I think it's important to figure out, you know, is it due to a genetic mutation, or maybe it's just a clustering of a few cases of colon cancer. Maybe there's some common risk factors, environmental or lifestyle factors that are similar. So I think that's the first step, is to figure out, you know, is it due to a genetic mutation, or is it maybe due to some common lifestyle or environmental factors? So if it's due to a genetic mutation, that's the most aggressive interventions, because that confers the highest increased risk for cancer. So with our genetic colon cancer syndromes, we can see, you know, over a 50% risk of colon cancer, often starting in the 20s or sometimes even earlier. So we do recommend starting colonoscopies at 20 to 25 and repeating every 1 to 2 years. As I mentioned, there's also other cancers that can come along with it. So sometimes other GI cancers like stomach cancer or small bowel cancer. So the doctor may also need to do an upper endoscopy, maybe not as often, maybe every 3 to 5 years, along with doing that frequent colonoscopy. And it's also important that, so let's say a genetic mutation isn't found, but there's still a couple cases of colon cancer in the family, we wouldn't say that that family's at average risk. There's still maybe something going on. Maybe we just can't identify it. So I think Dr. Ferris had said earlier, everyone in that family should be starting their colonoscopies 10 years earlier than the earliest diagnosis and repeating every 5 years. So I think my big take home for my families is, even if genetic testing is normal or negative, that doesn't mean that family still isn't at high risk. And that doesn't mean the family still can't get colon cancer or other cancers. So it's still important to know the family history and not to wipe it away, even if genetic testing is normal.
Good advice. Thank you. Another question for you, Emily. Can you talk about Lynch syndrome and what that is?
Yeah, so Lynch syndrome is actually the most common cause of inherited colon cancer. So I think I'd mentioned up to maybe 10% of all colon cancer is inherited. Maybe up to half of that is due to Lynch syndrome. And so there's actually 5 different genes that are associated with Lynch syndrome. So you can have a change in any one of those genes to be considered a diagnosis of Lynch syndrome. And that lifetime risk of colon cancer can range from anywhere from 50 to 80%. So that's why we do recommend starting colonoscopies in the 20s and repeating every 1 to 2 years. And some people say, well, no, why do I need to find out if I've already had colon cancer that, it was due to Lynch syndrome? Well, it can be important for them because it may change their next steps. So instead of, doing a smaller resection of the colon, the physician may recommend, a larger portion of the colon removed. If they know that person has Lynch or another genetic syndrome, they may want to do a more aggressive surgery. And then for women, they also have to think about that increased risk for GYN cancer. So with Lynch syndrome, we also see very high risk for uterine cancer, as well as ovarian cancer. And unfortunately, unlike colon cancer, we don't have effective screening for those cancers. So we often do recommend removal of the ovaries and uterus once they're done having children. So those are the main cancers associated with Lynch syndrome, and that's why it can be important to find out, even if you've already had colon cancer, that it was due to Lynch syndrome. It's also important for the family because if you have a Lynch syndrome mutation, it's a 50-50 chance that your children would also have that mutation, as well as your siblings and one of your parents. So it can really cascade down the family and be important information for the family to know as well. And then there are a few other cancers that we can see with Lynch syndrome, other GI cancers, sometimes pancreatic, small bowel, stomach cancer, even certain types of skin cancer can be related. So it's scary sometimes information to know that you're at high risk for all those different cancers, but a lot of my families tell me, knowledge is power. Now they figure out why all this cancer is happening in the family, and they can be ahead of it. They can know what to look for, and do these extra screenings and feel like they're more in control rather than it just being kind of an uncontrolled situation in their family.
Yeah, absolutely. I can see how that can be scary, but it's really great that we know that Lynch syndrome is tied to all those different cancers, so the physicians can look at that and help our patients throughout, with all of those potential risks that they have for other cancers. So as scary as you're right, knowledge is power, and it's important to know. Thank you, Emily, for that wonderful information. We do have another audience question and a comment. The first is a comment. This is for Dr. Ferris. This was from Bobby. He said, Dr. Ferris completed my colonoscopy and he was great. So some feedback for you, Dr. Ferris, from our audience. Thank you, Bobby, for that. And then we have a question. This is also related to colonoscopy. So I will ask this of Dr. Ferris as well, or Dr. Chen, either one of you who'd like to answer. This is from Nancy. She asks, do doctors stop doing colonoscopies on people at any special age? Do the elderly still need one? She's a colon cancer survivor. Congratulations to you on that, Nancy. So yeah, could you answer that question? Do the elderly still need colonoscopies?
So what I know of this, and I've had surgery residents with me. I'm faculty for years and family medicine as well. And it was a sharp family medicine resident tell me that their practice as primary carers is if you've gotten to age 74 or 75 and hadn't had a problem at that point in your life and never had a colonoscopy, don't bother. So I guess you would have seen something earlier if genetically, or even if you're the first in your family with colon cancer, you would have seen something by then. Now, to answer the question about I've had colon cancer already and when do I stop? Maybe Kevin wants to help me with that, or Emily, but to me, like an earlier answer I gave, it's so much easier to find a polyp and remove that than have to undergo a second surgery. So it's true that you can operate again on somebody who's had colon cancer and now a recurrence, but it's so much easier if you can prevent that kind of thing with the colonoscopy.
Yep. Dr. Chen, Emily, anything to add? Dr. Chen, you look like you were about to say something.
Yeah, I think I agree with, I agree with Dr. Ferris there. I mean, I think, age is sometimes just a number. Patients nowadays, there's different levels. If somebody who's 80 doesn't mean the same thing for everybody. Some patients life expectancy is always going up higher and higher because of all these advances we're making, and patients are just stronger and better health, better fitness, and so sometimes you can't just focus on the number and use the age as the cutoff, because sometimes we have these older people who still have a very good life expectancy. Everyone in their family up to 90, or they're in the best shape, and they're sitting there in 80 years of age, and you don't want to just say, you still have 10 years ahead of you. You don't want to have colon cancer throughout your body for those last 10 years of your life or less, because we didn't do anything about it when it was just a polyp. So I think it is sometimes you have to use some judgment with each individual patient to determine what makes the most sense for that person, and not just say strict, this is the age, I'm never going to do another colonoscopy on this person ever again. You have to use some judgment.
Thank you. Yep, that makes sense. Emily, anything to add from a genetic standpoint?
Yeah, I would just say for the guidelines for those who have genetic mutations, they're left pretty open-ended. I think for all the reasons that Dr. Chen just said, that there's not like just one individual age to stop the screening. It depends on their other health factors and their other history. And so I think I would advocate for patients that do have these genetic mutations, that genetic predisposition towards colon cancer, that they should be thinking about going above the typical age to stop, because they are at such a higher risk of getting a second colon cancer or getting another type of cancer. So I think as long as they can handle the screenings and it's not impacting their quality of life, that they should think about continuing those screenings.
Thank you. Well, thank you very much to all three of you. That's all the questions that I have for you. Well, I have one more, all the formal questions that I have. But I did want to, before we wrapped up our broadcast, I wanted to ask each of you, what is the one message, a key takeaway? I know we talked about a lot and shared a lot of wonderful information. So I encourage everyone to watch the replay. We talked about colorectal cancer, what it is, the risk factors, treatments. We talked about colonoscopies and genetics. So I encourage you to go back and to get all the information, share the broadcast with your friends. But just before we close, just what is that kind of one message or key takeaway that we want to make sure that people go away today in the top of their mind? I'll start with Dr. Ferris.
I mean, this all adds up to colon cancer is preventable. And if it's discovered early, you have so much a better chance for cure. So that's what this all boils down to.
Yep. Thank you so much. That's a good takeaway. Dr. Chen.
Yeah, I mean, I agree. I mean, I think 1 in 5, colon cancer patients present with stage 4 cancer, that is incurable. You do not want to be in that situation. And again, the earlier the stage, the better the outcomes and the less toxic less toxic treatments you need. You don't need as much chemotherapy. You don't need radiation always. You do less and you have better outcomes if you just, do the screening, get caught early, then everything will be so much better. So yes, I agree. That is definitely the take home.
Thank you very much. Emily?
Yeah, I agree with everything that's been said. And I just think, as we talked about before, that knowledge is power. I think there's a lot of myths surrounding, colonoscopies and as well as genetic testing. So I would just encourage our viewers to just learn more. Sometimes something you hear or read isn't always true. So just kind of seek out information from your healthcare team and learn more about colonoscopy and also about genetic risk factors. And if genetic testing is something you should consider, because early detection is definitely key. Knowledge is power.
Well, thank you all so very much. I know I learned a lot. I know our viewers did as well. Thank you for sharing all this wonderful information. And if you'd like to learn more for our viewers, want to share, you can call 866-932-3506 for more information or to schedule an appointment. Thank you so much for your time. To our experts, thank you for watching, and we will see you next time.